Let me start with the advantage. So because for screening severe combined immunodeficiency SCID, we utilize real-time PCR to check the T-cell receptor exertion circle. When we do screening for SMA, we also use the same technology and trying to detect SM1 exon deletion, the homozygous. So we could utilize the same platform. And because we already have a test system, you only need adding on a set, primer, and a probe to target SMN1. So that will be very cost effective, not just reagents, also about staff time. And the disadvantage, I don't see any. The one thing I wanted to emphasize is, like any test, if you add in a new component, you need to do another assessment verification, indicate nothing will have a negative effect on your assay, and you should be ready to go. For SMA2, you could have a different technology, and I have experience with called droplet digital PCR, because that technology compare real-time PCR, they have a more accuracy in terms of assess the copy numbers. And not only theoretically, practically we have done validation in our laboratory, and we are able to accurate assess the SMA2 copy numbers with a different, like 1 copy, 2 copy, 3, and 4 when SM1 exon deletion be detected. I wouldn't say it's a must, because screening for SMA really is SM1 exon homozygous deletion. And because SM2 copy numbers affect the severity of SMA, so it will be nice to know the copy numbers, but these copy numbers can be done in the screening laboratory, also can be done in other places. For example, could be done in the confirmatory test process. Yes. The one example come to my mind is a lot of discussion talk about congenital CMV, and I do believe, based on the technology, the accuracy, droplet PCR should be performed better than real-time PCR come to the gene copy numbers. So if we want to detect congenital CMV infection, if you use the CMV virus DNA copy numbers, I can foresee the utility utilize droplet digital PCR.